Well, good afternoon. As Ian said, I'm Steph Meyer. I'm from the Minnesota Department of Health, and I supervise an epidemiology and data team in our infectious disease epidemiology prevention and control division. And today I just wanted to talk a bit about Project CLARE, which is our large language model pilot project for medical chart reviews. And some of you might have heard about this project before. We did present about it at CSTE, but we've expanded the project and added a little more to it. So hopefully for those who have seen parts of this, parts of it will also be new. So just a little background information on some things we do at the Minnesota Department of Health. So COVID-19 is one of many reportable diseases in Minnesota. I know it's not reportable in every state since the pandemic, but we have kept it as a reportable disease. So physicians are required by law to report COVID-19 cases to the Minnesota Department of Health. And Minnesota is also part of the Emerging Infections Program. And as part of that work, medical chart abstractions are often necessary. And I'll talk about that in a little more detail as well. But what I mean when I say chart abstraction, or sometimes I say chart review, that's where we're condensing the elements of a medical chart and the data that we need to make determinations about population health. So when we say that a certain percentage of people who had a severe COVID infection, maybe they were also obese or they had kidney disease or other problems, we're comparing outcomes in medical charts to say that statistically this is unusual or that an outcome that matters, this is an outcome that matters and it has implications for the health of the people in our state, in our nation, or even worldwide. And COVIDNet is part of the Emerging Infections Program. And in that project, we monitor laboratory confirmed COVID-19 associated hospitalizations among children and adults. And one of the tenets of that program, or one of the parts that we need to do that work, is the chart review or medical chart abstraction. One of our Minnesota state agencies, Minute Services or Min IT, they house all of our IT staff. And I think the same is true in many states where there's a separate agency that operates with IT staff in a centralized manner. So they recognized the importance and promise of artificial intelligence to bring some innovation to digital government work. And Minute created TIGA in Minnesota. So that's our Transparent Artificial Intelligence Governance Alliance. And the purpose of this group is really to provide clear information on how decisions are made and oversight of AI work in Minnesota government. And they also adopted a public artificial intelligence services security standard. And I really want to emphasize this because having this TIGA framework is what allows us to do the work that we do at our agency and have oversight and governance so that when anything comes up in government or from the public or from anyone about questions on how we're using AI, what is allowed and isn't allowed in the state, why are we doing things a certain way, all those security reviews that have to go into the work that we do, it is all governed under TIGA, and it's really provided the backbone for an infrastructure for us to be able to explore these possibilities. And I think it's a really important piece that people put in place in Minnesota. And we had some really ambitious folks in the IT group here at the Minnesota Department of Health who wanted to form this alliance and this group, and they were a really key part of creating it. And our project Claire was one of the first things that came before TIGA. We helped sort of pilot their infrastructure of how will we review things, what will we look at, and our project was kind of the right size and scope to start with. So it was a really good cooperative effort. So just to sort of level set our understanding about medical chart reviews for those that are maybe less familiar, when we're doing a medical chart review, we're just really looking for answers to specific questions and trying to determine the course of a patient's illness or the course of their hospitalization. This might include getting admitted to the intensive care unit or being discharged to a rehabilitation center or any number of things. We also look at the treatments that a patient was given or underlying conditions that might affect what's happening to them. And we collect all this data and enter it into a REDCap database. So all participating sites across the country collect data uniformly and record it. And you can see here in just a sample of what would be in a patient's chart. Um, there's data that's often recorded multiple times or multiple days. If any of you have been hospitalized, you know that people are always coming in to check your vital signs, they'll check your temperature, your pulse. Those things are recorded in multiple places in a chart. And sometimes there are paragraphs of text. There might be codes and diagnoses and prescription medications present in a chart. All of these things have to be reviewed and looked through for these chart abstractions. So you can imagine that that manual medical chart review really can involve multiple staff. The COVIDnet program includes a sample of hospitalized COVID cases for chart review, and you can see that thousands of chart reviews have been completed each year, and we did over 20,000 in the early part of the pandemic. And the cost of full-time staff to review thousands of charts is not tenable, and particularly as we look at funding limitations and other barriers. So in the CLARE pilot project, we really had this goal to streamline that work and to look at it in a more uniform way to improve our quality. I should say also that just the amount of time that it takes for individual staff to do the review can be pretty extensive. Some of the medical charts are 100 to 200 pages long, and when you're asking staff to really comb through that and find answers to questions, it is very time consuming. So in our pilot project, we identified 150 COVID-19 medical charts from just one health system for the 2022-2023 respiratory season. And all of the charts were redacted PDF files, and they had all been manually reviewed by our full-time staff with answers entered into a REDCap database. So we already had this, sort of a gold standard data set to draw from. And we partnered with our Minute at MDH, so our IT staff who are embedded at the Minnesota Department of Health, and Amazon Web Services to evaluate our options. And we chose Amazon Web Services mostly because they are our cloud service provider. We've had good interactions with them, and they were interested and ambitious about this project. It was a good partnership. And the analysis of the results from the text extracts from abstracted charts from this AWS pipeline that we built that I'm going to describe were then compared with those manual abstractions that I mentioned. So we're looking at these 150 charts in two different ways, manually done by people, and then also abstracted through our CLARE project. So the basic process developed with our Amazon Web Services partners included multiple steps, and it really begins with a medical chart going into an Amazon S3 bucket. And that's just Amazon's term for a cloud storage service. It's just a cloud bucket where we can place files. And this triggers an AWS step functions state machine, which is really just a pipeline that groups together and organizes a series of tasks that either need to occur dependently or sequentially within our Amazon environment. And from here, the first step is text extraction using Textract. We've tried using the Textract tool in the past. It has evolved quite a bit over the years. We found it to be really useful in this instance, and it helped us just convert our chart into a machine readable format and put that output back into our S3 bucket. But even this small loop as part of our pilot project really was something we put a lot of time and effort and thought into, because if you can't get a good machine readable format output in the first place, you're really kind of sinking the whole project. So we did a lot of review of what do these text extracts look like? Is it matching up with the chart? Did it really extract everything from the chart? And we found that in general, it was doing a great job. There are things like illustrations in a chart, or if there's an EKG readout or something else, it can't necessarily translate that into machine readable text. It had a little bit of problem sometimes with tables that are embedded in charts, but for the most part, it really did a good job. And any problems that we found, we were able to modify and continue to work on until we got better output. So that was the first loop of our project, was just converting these PDF files into a machine readable format. And from there, we move into text chunking and vectorization. And this is a piece that at least I was unfamiliar with when I started the project. I think sometimes it can be kind of a confusing concept, but what we're really doing is breaking the extracted text into smaller text chunks. And in this case, we used Amazon's large language model, Titan. And these chunks of text are then converted into vectors, which are just numeric representations of text using embeddings. And I'll talk about an example of this in a minute. But this is really a key part of semantic searching. We're not doing keyword matching, but we're doing concept level matching. And this process is what lets us rapidly match relevant chunks of information with field definitions or prompts. And the vector representations get stored in a semantic index. So we're organizing these chunks of text by meaning rather than keywords. And that lets us retrieve the most relevant pieces of information based on conceptual similarity. So here's just sort of an example of what I mean by that. Medical charts and these PDFs, they're too long for an AI to read all at once. So the system's going to split it into smaller pieces of text called chunks. And in this example, you can see I just made up an example chart text where you know a patient is admitted with fever and cough. They're prescribed ceftriaxone by IV. Blood cultures are positive for Klebsiella pneumoniae, and the patient is discharged after 5 days. So that whole bit of text, I mean, let's just assume that's a condensed version of a chart. So the text chunking is going to take each line of that and make it its own chunk. So an example chunk would be prescribed ceftriaxone by IV. And then you convert that chunk into a numeric representation of meaning. That's what an embedding is. So in this instance, that means that string of numbers there, the 0.21, negative 0.88, all of that. These numbers put the text in a mathematical space where similar meanings are close together. So a normal keyword search is going to look for exact words. So you might ask something like, what antibiotics were given? And the chart says ceftriaxone IV was started on such and such a date. The keyword search is going to fail because the word antibiotic isn't there. But embeddings can understand the semantic similarity. So ceftriaxone, antibiotic, antimicrobial, these are all going to be related concepts, and the chunk can get retrieved. That's what we mean when we say semantic searching. So you can see across the bottom, I have what antibiotics were prescribed, and it's coming back with these chunks. Prescribed ceftriaxone is the closest match. It can see that that's the answer that I'm looking for. So after we do the text chunking and vectorization, that leads us to prompt-driven large language model searches. So we used different large language models. We gave them sets of field definitions defined through our COVIDNet protocol, along with specific prompts to just help it search efficiently. And the large language model goes to the vector store and it tries to match with these defined concepts. And these two steps, that text chunking and vectorization, combined with the prompt-driven LLM search, is really the full RAG process, or sometimes you hear RAG or retrieval augmented generation. That's that whole piece. I'm just representing it here in a more granular view. And then lastly, we got a field matched JSON output, which we saved back as a file in our S3 bucket. So that gives us the full process. So again, from left to right, We're converting the files into a machine readable format. So the files being a medical chart, we're converting that into a machine readable format. We're chunking that text into vectors, putting them in a vector store. We're using prompts and various large language models to search the vector store for those concepts. And then we're saving an output with the answers to all of our questions. And that's just a full pipeline to give us one big piece of output for one chart. And then we're repeating that over and over again for all of the charts in this pilot project. And throughout the project, we really looked at various data elements and corresponding accuracy. And we divided our data into 4 different categories. And the first of these was structured data. This is data that where we thought the data collection might be better suited to standard code and really more of that keyword searching methodology, things like weight or height, just something that's a deterministic variable. We just want it to find the exact weight or height of that patient and report a number. And then the next was prompt-driven search. So this is data that might require some decision making based on additional information. If you're maybe classifying a type of antibiotic or antiviral treatment, that would be something that might be a prompt-driven search. The next category was probabilistic matching, and this was data collection that we just thought might work well using a large language model or other AI resource. And some of that was just, I mean, us not really knowing exactly what to put into this category. We decided it was things that are maybe concepts or nuanced data like family history, things that might be in these long paragraphs of text. And then lastly, we had these summarization variables, and these were data that we thought might require some manual review by staff, but having some kind of summary out of the chart with citations might help us streamline that work. And, it should just be noted that we also thought large language models might help us in that process to just further streamline our data analysis from those summaries. And this is the key piece where we want a human in the loop. We want a portion of this work to be the creation of an augmentation tool. We're not necessarily replacing all the needed people, but the speed with which we can do these reviews is going to matter, as does the quality and quantity of the reviews. So we looked at accuracy by each of these categories. So you'll recall that we had these 150 charts to begin with. We had already manually reviewed them. We'd had people review them and answer all the questions and enter it into a database. Then we ran the charts through our pipeline and got an output that was, equivalent to our database. So we could compare those 2 data sets. And this is the result of that comparison. So structured data, there were 76 questions that we really thought were more structured answers. And you can see that the average accuracy for those fields was lower. It had the lowest accuracy by large language model assessment. The same was somewhat true. I mean, better percentage, but somewhat true for summarization variables. They also had a lower accuracy score, and that just underscored our desire for some additional review and the need for further processing. But the structured data piece really gave us the indication that our thinking was perhaps right, that standard code might be a better model for those pieces of data. And then, of course, the thing I'm not highlighting here is the more successful part of the prompt-driven search and probabilistic matching categories. We really did have a pretty high percentage of accuracy across those variables, and we were glad to see that piece come through. So we went back through our prompts and we tried to refine a lot of the variables and the questions that we were asking, because we realized that in the partnership we had with Amazon, a lot of the code that was written for the prompt-driven searching, I mean, it was written by Amazon developers who in some instances were less familiar with some of the nuances of questions and maybe didn't know what some of the variables meant. There were things that were probably missed in the grand scheme of all the questions that we ask. So we went back through and refined some of the prompts, and then we ran this again to reevaluate the pipeline and compare it. So if you look at our original pipeline, we reran it because we also wanted to run it using updated large language models. And then we use those same large language models to run it with our new pipeline with the refined variables. And you can see that refining the prompts did result in higher scores, but we still found some lower accuracy in the structured and summary variables. And just, some changes in our output that we wanted to understand a little better. So our next step was to try and look at a chat bot that could help us with parts of the chart that maybe might be a good thing to add into this pipeline. We're not exactly sure what the order of operations would be, but we know that there are some variables where we just need to dig into it more and understand more about how to prompt correctly to get the answers we want. So we worked with our IT staff to build sort of Claire Part 2, a medical chart analyst assistant or a chatbot. And it's really just two pieces. There's an application front end with a chatbot interface and a file upload section, and then an application back end that processes text prompts, communicates with the AI agent, and handles the file processing and the creation of Amazon Web Services resources related to the document and the model. And we thought that this would really give us an opportunity to further explore some summary variables at the start. We wanted to look at specific dates for admit and discharge. It does get complicated in some chart reviews because people might be admitted multiple times to the hospital. Sometimes they're not discharged back to their home. They might be discharged to a rehabilitation center. Sometimes there's transfers to different hospitals. There might be ICU in admissions and discharges. Some of those dates get really complicated, and having a way to review those in more detail is helpful. There's a lot of data about respiratory supports that are very specific to COVIDNet as a program. So understanding if someone has a nasal cannula, if someone has, full intubation, other respiratory supports, and exactly when that started or stopped or what it meant for the patient's course of illness is important. And then there are a number of questions about pregnancy, how far along someone is in their pregnancy, things about being admitted or discharged due to pregnancy. All of those things might just require additional review. So the goal was to get a cited output for each chart where we're asking questions and it's telling us where in the chart is this information, what's the answer that the chatbot is coming back with, and where did it find that information. And even having citations is something that helps us in terms of time for chart reviews, because you can imagine that a 150 or 200 page chart takes a lot of time to review. Just knowing what pages to go to and where to look can be a helpful first step. So this is sort of a rundown of our chatbot. There are some really basic steps that occur. I mean, it's maybe something that folks are more familiar with, and I'm not sure if I'm going into more detail than people want or not enough detail, but we'll sort of try and strike a balance and talk through it. The idea is that a user would first interact with a web interface. And in our case, we used Streamlit as a tool. That's just something that lets our developers quickly turn Python code into a simple web application. So instead of them having to build a whole complicated website for us to look at or use, the Python code can just say things like show a text box or a chat window, or it can have a button to upload a file, have a screen to display some results. Once you write that into the Python code, Streamlit just automatically turns it into a web page. And then that's going to allow us as the user to upload a medical chart and start asking questions. So after we have that, we have a Strands AI agent that will accept whatever prompt is typed into the chat. So in our system, the Strands AI agent is like, controller. This is the logic layer that really orchestrates the AI behavior. It's going to receive the question, decide to search a knowledge base, retrieve information. It's going to send that to a large language model so that we can get a response. And we can use any large language model. Amazon Bedrock is the platform that we use, and it just would provide us access to whatever large language model we choose. And then we also have AWS. We have an AWS API that lets us query our knowledge base for relevant information, and that's called the Retrieve and Generate API. So the agent is using the retrieve tool to get information from the knowledge base, and then using any large language model we choose to get a response. And so we're still using a RAG process, or that retrieval augmented generation process, just in chatbot form, because we really want to retrieve relevant information from the document we're providing, like from the chart that we're uploading. We don't want to allow the response to be sort of outside of those bounds. And we're trying to be cautious in having the system provide, I don't know, for an answer if the question is out of context or beyond what's available from uploaded documentation. And then we also want cited output, as I mentioned earlier, that'll tell us, really where in the chart is this information found, and can we verify it? So we can use this full process to get that data, and the agent then forms a response back to the user in the form of a conversation, which I think almost everyone on this call will be familiar with what that might look like. So really that brings us to what our next steps will be. With adequate funding, we're really hoping to continue our CLARE pilot. We want to use more cases, more file types. We want to include more medical providers. We're hoping to look at charts in other disease areas, explore the use of large language models with electronic case reports, which are another mechanism of disease reporting in our state as in many others. And we think that large language models combined with deterministic code might be a smart hybrid approach to medical chart review and could result in a more efficient use of our staff time. And using a chatbot in combination with our large language model pipeline might help us streamline our work and serve as a check for some data errors. We're sort of exploring what that would look like and where would we put a chatbot in that process? Is it something that we do at the start? Is it something that kind of happens in the middle? What's the right way to do it? Can we create output from using a chatbot that is maybe part of the knowledge base for our full pipeline that would help us get better answers? We're not sure, but we're looking at all the possibilities. And then ultimately, AI use could thus expand our ability to use medical data directly from providers to better understand population health, which I think is the goal of everyone here in this group. So that is what I have. Thank you.
Great. Thank you, Steph.